I said this morning that we will welcome Neil Lane as our afternoon plenary presenter, and he was recently appointed AARP's New York State President and serves as lead spokesperson for AARP New York with the media and opinion leaders, legislators, and the public. He has a great PR. The announcement was really wonderful. He also chairs, it was great. He also chairs the AARP New York Executive Council, and they work on services for older adults and issues around older adult issues for New York's 2.5 million members, which is pretty amazing. And he served on the council as a council member for AARP's National Policy Council that really looked at state long-term care issues and national public policy recommendations. So he's led a number of organizations. He was the director of the New York State Office for the Aging under Governor Pataki and has served on a number of boards. And he will help us understand this afternoon the broad-ranging impact of changes in healthcare and aging policy systems from both a policy and practice perspective. He'll outline the sea changes that are occurring in the delivery of healthcare and long-term care to older adults as a result of the Affordable Care Act, which I know impacts all of us, and the resulting impact on community-based organizations and practitioners. And he will also give us some information about how the proposed changes to Medicare and Social Security might impact older adults. Again, turn off the ringers on your cell phone. And thank you, and we are very grateful to Neil for his generously agreeing to come and present at this year's colloquium. So it's yours.
Oh, thank you so much. Just a disclaimer, and that is today I'm not representing AARP, I'm representing Neil Lane. So Beth Finkel, who's here, needn't worry that I'm going to go off message for AARP. So if I could remember the words of those disclaimers, I would issue them. But let's get started. I'm so glad you're here. The word sea change was used, and I would say sea change is exactly right. And I think all of us need to imagine where we'll be in 5 years after the full implementation of the Affordable Care Act, or as the President himself calls, Obamacare, and as well as the Medicaid redesign that's going on currently in New York City and then the rest of the state. So let's begin with an overview. I'm going to talk briefly about the Affordable Care Act. I'm going to talk about some opportunities and some challenges that are present with that. I'm going to talk about New York State's Medicaid redesign briefly, and also there are opportunities and challenges with that. And now I'm not going to talk about any of that. I'm going to briefly talk about the Administration for Community Living. Everybody knows what that is or does not know. Okay, that is the melded federal agencies of Administration on Aging, AOA, and the entity that advocated for and represents younger persons with disabilities. So they've integrated those two entities that's still under the Secretary of Health and Human Services. But I raise it because I think it's illustrative of some changes that are going on, and how do we react to them and how do we feel about them? I must tell you that I'm ambivalent about this change. And I see some pros. The Administration on Aging has been dead in the water for a decade probably in terms of funding and moving the ball forward, with some notable exceptions. Their work with CMS on building out the Aging and Disability Resource Centers, which I hope New York City will embrace at some point, the ADRCs. So there has been some movement, but basically there hasn't been any real increases in funding or real momentum in terms of legislation and action. So maybe this change will help with that. I don't know. We'll see. Spoke about the ADRCs. This configuration of bringing these two federal agencies together models the notion that's encompassed in the Aging and Disability Resource Centers. And that is that regardless of age, if you are experiencing difficulties in remaining in your community and meeting your preferences and your desires and your goals, you have challenges, regardless of that age. The ADRC is designed to serve them. So perhaps this will model that as well at the federal level. Sure. I thought she was going to hit me with something, but thank God she didn't. So, by the way, if anybody, if you know, this is after lunch, and that's always one of those times where your digestion and sugar and all that, and then you kind of go down. So if I fall asleep during my presentation, I'm going to ask Beth to wake me up so we can continue on. And in theory, by combining these two entities at the federal level, there may be some more resources. We may get some movement, and for perhaps the wrong reasons, but we may get some movement. And I'll talk about those wrong reasons. Messaging is a concern with this consolidation. Now it says, Administration for Community Living, but it gets branded as the agency that serves people with disabilities. Well, you know that AOA is much broader than that. It serves active people, it's prevention, it's on and on it goes, senior centers, etc. So I'm concerned about how this gets branded, and the messaging is very important. And here's my other bigger concern. In Wisconsin, what they did was on a regional level, they provided a capitated budget for all long-term services and supports, regardless of age. Okay, so within this one region, they had a global budget of $10 million or $20 million for a year for service. And it served both young and old who needed long-term services and supports. So what happened in Wisconsin? Well, what we witnessed was a diminution of resources going to older adults and an increase in those monies going to younger adults. Younger adults were deemed, in this case, more worthy. I mean, those were the decisions that were made, and frankly, it reflects a greater concern of mine of ageism in this country. And so, if you are in a competitive pot of money with younger disabled, your odds go down that you're going to get the services. So that's a concern. Now, the good news is that Wisconsin fixed that. They saw what was going on, and then they adjusted how they funded these regional long-term services and supports so that inequity was taken out and equity was restored. But I think the message is it's a clear picture of what can happen if you're not diligent, thoughtful, and aware. And it's not a zero-sum game. It should never be a zero-sum game where we serve one population and not another. That's not acceptable. But we do have to be diligent and thoughtful. So that's why I'm a little concerned about this federal direction. Okay? Now I'm going to get back on message. And that is, I want to talk a little bit about the Affordable Care Act, or Obamacare. There have been, as you know, a number of states who have refused to implement the health benefit exchanges, and I would also say, since the Supreme Court ruling, many of the states, a number of the states, not many, I think it's 12, have also decided not to expand Medicaid, which was part of the Affordable Care Act. Now, that's not New York State, so we're all right in that regard. So what opportunities exist for your organization or community-based organizations within this more louder or more direct notion of the Aging Services Network? I'm going to lump you all into that big bucket because in some ways you serve older adults regardless of whether you're adult protective or Sunnyside or who you are. If you're interested in the well-being of older adults, or I wouldn't think you'd be here. So one of the major opportunities I didn't do that. Oops. There I go. One of the major opportunities is in hospital transition. This is a big deal. This is a big deal. The federal government, researchers estimate that hospital readmissions to hospitals, approximately 30% of them. The research is kind of broad. It goes 10 to 30, but I err on the upper side because I believe that's what it is. 30% of readmissions are preventable and older adult readmissions. This is a lot of money. This is big, big, big money. So the federal government is putting into place initiatives to reduce inappropriate hospital readmissions. And in so doing, there are roles for community-based agencies to play in that, to partner with entities that are working on this problem. Because what we know about people transitioning back to the community is that the needs tend to be social in nature, not medical. They tend to be lack of transportation. They tend to be no motivation or no ability to do the follow-up doctor's call. And the third major reason is they don't have access or can't get their medications. So those are the three major reasons that people are readmitted to the hospital. Three reasons that you folks, community-based entities, have the ability to play a significant role in. So I urge you to do that. So we also now have, under the ACA, community-based organizations can become enrollers. How many of you knew about that? Okay. So just a very small number. That's a problem. Because enrollers for the ACA support people, many of whom will be between the ages of 50 and 64, who need support in filing for their health insurance beginning in October 1st. All those have been chosen, so all you folks who didn't know about that are not going to be in this first round. But you should be aware of it, because your entity, your organizations, perhaps there'll be an opportunity down the road. This is what you folks do all the time. In-person assistance to people navigating confusing systems. There were a request for proposals issued by the Department of Health, which closed in April. They have not announced who the selections are, but how many of you knew about that? Okay, we've got to get our heads around this stuff, folks. I mean, I'm speaking to you as part of the brotherhood, sisterhood of aging services. I've spent my entire life in aging services and services to frail populations, and it's pretty clear to me that the train is leaving the station, has left the station, and we either got to get in a car and catch up to it on the next station, or we will gradually become less and less relevant, because this is the wave of the future. Oh, here's another one. How many of you know about or participate on regional advisory committees for ACA, the implementation of ACA? Okay, again, not a very large number. This is an opportunity, because this serving on your regional advisory committees on the implementation of ACA gives you a voice at the table, always worth your time. Okay, this is, I guess, am I stepping into the Medicaid redesign? Yeah, okay. You know about Medicaid. If you're in New York City, you sure know about Medicaid redesign, right? You know about managed long-term care and managed long-term care programs and delivery issues associated with that. I just attended this is an unabashed plug for the workshop that Rachel and Paula gave about the difficulties in terms of serving older consumers within these models and some of the challenges that occur. Okay. Another word about the Affordable Care Act. I mean, there's a lot, I have to do this because the perceptions of the Affordable Care Act or Obamacare out there are not the public perception is not very good. I mean, I think it's like 40% support Obamacare and some don't, and so we need to do a job. But the older adults, I hope you all know, were the biggest winners with the adoption of the Affordable Care Act. There's now an emphasis on prevention in Medicare. There is access to insurance for older adults who are not yet eligible for Medicare, and those are 50 to 64-year-olds. 30% of our population in New York State in that age range do not have health insurance. Do not have health insurance. And that's not a good thing for them and not a good thing for us. And you know that the Affordable Care Act, pre-existing conditions do not matter when it's implemented. Supposedly there'll be a choice of plans, some just basically catastrophic and others more enhanced, so there'll be some affordability things there. And we closed the donut hole over a long period of time, but we closed the donut hole for older adults and their prescription drugs, and that's an important victory. The accountable care, this is a whole section of the emphasis of the ACA, accountable care. They talk about value pricing and various other schemes, but they're focused on accountability. Not, the old system that we've had has been all about the input. So if the doctor gets paid for every visit, the nurse gets paid for every visit, et cetera, et cetera. So there's an incentive, obviously, to overserve. Accountable care, the notion is that should disappear. There should be different payment models which don't pay on a per visit basis, but pay on outcomes. Now, we've got a long ways to go to get there. Does he have okay. But one of the notions, of course, in accountable care is care coordination. Now, that's something that you folks can participate in, and we'll talk about that. Okay, I've already talked about reduced hospital admissions. So you're in this big lump. I'm calling you the Aging Services Network. How do you match up with the goals of the Affordable Care Act or Obamacare? How do you match up? Well, your network is very successful at reaching difficult to serve populations. That is a primary goal of the Affordable Care Act. It's a trusted resource for older adults. And that's terribly important when you talk about engaging older people in service, in a new service system. Who do they trust? Well, the good news is they trust you. You are accustomed to supporting individuals and in choosing in their choices and helping them to enroll in complex insurance products. The Aging Network, whether it's you or DFTA or whoever, has worked with the HICAP program and other insurance counseling programs for decades. I mean, the skill set is there. We've done this for decades in the Aging Services Network. The Aging Services Network is experienced in determining or assisting in determining eligibility for financial eligibility and fiscal eligibility for various programs. That's your skill set. That's a part of your skill set. So these assets match up very well with some of the ACA requirements. One of the requirements is to reach out and engage and support populations as they access the health benefit exchanges. And you know, October 1st, New York's health benefit exchange goes up. And insurance coverage begins January 1st. So it's coming. So provide health insurance counseling to and advocacy on behalf of consumers. That's in the law. The law says that we must do that. It also says we have to facilitate enrollment into approved insurance products, including Medicaid, managed care, especially for diverse and hard-to-reach populations. These are your people. These are your people. And there must be mechanisms to determine eligibility for the health insurance subsidies in Medicaid. So we'll continue with this. Your network understands the locale's home and community-based services. So if you're in Western Queens, you know who the providers are, how those systems work or integrate, or who you can call and how you manage that. And home and community-based services and supports for frail, at-risk individuals, especially case management, is a requirement under the ACA. Okay, reduce hospital admissions. If you are in the community and doing community-based case management, you're in the right place to help with that. Reduce costs associated with duals. Duals are people who are eligible for Medicaid and Medicare. They generally have a higher expense, public expenditure rate, and they generally have, and I use the word generally, have a larger number of chronic care or chronic conditions to manage. Now, the ACA calls for the development of community-based health teams. So I'm urging you now to pay attention to this, because community-based health teams and how they're defined and described, they talk about not just health professionals, not just a doctor, not just a nurse, but they talk about community-based organizations working in concert with community health centers and health centers for community health-based teams. Strengthening people's choice in how and where they receive long-term services and supports, and increasing the availability of home and community-based services. Now, one of the things that frankly concerns me, and it's not like I haven't said this to the Department of Health, is that within the Affordable Care Act, there are grant programs for states to expand community-based care. And one of them is BIP. Another is Community First Choice. And BIP, I never remember what it's balancing, on and on it goes. But the key factor in those two grant programs, and these are big, this is real money. I mean, if you talk about in BIP, reducing the state match by 4%, I mean, that's $1 billion+ easily. And that's a lot of money. But in those programs, it requires a comprehensive assessment, evaluation of the consumer that is conflict-free. Conflict-free. What does that mean? That means you can't be a managed long-term care plan because you have a stake in the outcome of that assessment and do the first or initial assessment. So I'm going to be very interested in seeing how the state, because the state has filed for BIP. And it'll be very interesting to see how they address this. But I would urge you to be right on top of this, because many of your organizations are competent and skilled in providing assessment and care management for frail older people. This will be very, very important. You are a strong advocate for at-risk populations. This asset matches up with the ACA requirement of having the PowerPoint work properly. and identifying and report insurance provider malfeasance in the marketplace. That's a role that needs to be played by somebody. The network has successfully diverted frail individuals to community-based care. That's a goal in the ACA. And you've participated in initiatives to move or transition people away out of nursing homes back to the community. That's a component of the ACA. And the network has extensive reach through the Ombudsman program into the state's nursing homes. And all these match up beautifully with the goal of the ACA to transition persons who can from nursing homes back to their communities. I'll talk about that. Now, in New York City, it's been reported that a number of people actually end up in nursing homes basically because they're frail, but they also don't have affordable housing. And so that the state actually is going to be working on that issue, and I hope I get to it here. Okay, I've already mentioned this. Yeah. See how I did. For nutrition, I forgot that one as well. Most of these issues that result, I'll just say this again, result from non-medical care management, the lack of. So this is a terribly important role that you folks can play. All right, now we're talking about entering an arena of healthcare, because this is the rubric that this wraps around, right? Healthcare. You're not of their world. Now that some of you may well be, or some of you may be used to partnerships. But most of us are not accustomed to working with healthcare providers. More importantly, healthcare providers are not accustomed to working with you all. They're used to working with other healthcare professionals. That's how they see the individual. They see the individual as a patient, not as a consumer, as a patient, to be protected, to be cared for. It's a different mindset than perhaps you in the community-based services have. They probably don't have any idea. So a lot of these let's just use managed long-term care. A lot of these managed long-term care don't have any idea how important your services are to supporting frail people and what your organization does. Many of them just don't see that you have a role to play. But in fact you do, an important role. Their traditions and philosophy of care in the medical model system is very different than maybe your care model. Community-based organizations and usually have a philosophy that has to do with respecting the independence, choice, dignity of the individual, and having that be an important element in what services are provided. That's not the tradition of healthcare. They are accustomed to working with other healthcare professionals, not with community-based agencies. They see the person as a patient requiring medical intervention. The attention to social supports that's not been their training. They have little or no training on the importance, there I said it twice. But these are real barriers. These are real barriers for you working within the healthcare system, in community-based health teams, in managed long-term care, in accountable care organizations, and the like. And we have to overcome these barriers. But they are there, and we just can't ignore them. I probably say this someplace else in the slide, but I'm long in the tooth enough to remember when managed care, healthcare, came to New York State. And I was excited about it. I thought, well, this is great. There's going to be, incentives to reduce care. And we knew in the Aging Network that a lot of our work did do that. I mean, good nutrition reduces healthcare utilization, socialization, transportation, all the things that we're accustomed to delivering worked in that model. But did we ever get integrated into that model? No, we did not. No, we did not, because of the barriers that I've expressed. There are some peer learning opportunities that you can look at. The New York State has funded some community-based care transition programs, and these programs have been successful, and they incorporate you folks. They incorporate aging service network providers in their delivery models. There are 2 counties, though I'm not sure where Albany is now, but Tompkins continues to be community supports navigators. Those are people that are of the aging network that follow individuals from the hospital to home. And they're folks just like you. They're not medical, they're not. So there are some models to look at. So we know that managed long-term care and Medicaid is an enormous undertaking. Medicaid in New York State is, the last time I looked, $54 billion of a $120 billion budget. So that's a pretty big chunk. So what's my point here? Well, our future is going to be very different in home and community-based services for frail older adults, because that 54 billion pound gorilla is going to drive change. Now, we all know we do it ourselves. We go where the money is, right? That's what Willie Sutton did. Why do you rob banks? That's where the money. So we go where the money is. Medicaid is by far and away the largest funder of long-term services and supports in this state. So what do you think providers are going to do? Well, in 5 years, when Medicaid managed long-term care is the delivery model throughout New York State, will there be consumers accessing services as they are today, or will it all be in managed long-term care? Will it all be there? I think there's a real possibility it will, because I know that anybody who wants to be a viable entity is going to have to play in this game to get Medicaid long-term services supports. Who will you be? Can you adapt with your current mission, or will your mission need to change? Our history is problematic. A thoughtful business plan is essential. You really now have to put a different kind of hat on than what you're accustomed to. Now, I grew up in the Aging Services Network where we got defined grants to do whatever, transportation, meals, etc. That day is going to be coming to an end. And it's going to be money follows the person, and you're going to need to be entrepreneurial and have a business plan for that environment. I knew it. It was so funny because Len, we were sitting together at lunch, and Len said, you know what? Somebody's phone is going to go off. And I said, you're right. You're right. Okay, Medicaid redesign is intending to move all Medicaid recipients into long-term services and supports that are managed care. There are a couple of types. Fully capitated. This is what they're actually going. You know, they don't tell you this at this stage of the game, but this is their end game. This is their end game. They want everybody to be in fully capitated systems. Now, we don't have, there's only a few of those now, but that's the direction the state health department's going in. We have a lot of partially capped, yes. All medical and long-term services and supports. Physician, they'd be at risk for physician, hospital, physical therapy, all of those things. That's where the state wants it to go. Okay, we're not. That's their long-term game plan, and they may or may not tell you that, but that's where they're headed. There's a new waiver which purportedly will save the feds in New York State $2 billion a year over 5 years. A portion of that money is going to be going to New York Connects, which is New York's Aging and Disability Resource Center. I know New York City does not yet have one of those. I would urge you to rethink that, because this is going to be real money, and it's going to be focused on community-based care and keeping people in the community. That's the job of an ADRC. And the waiver implies a commitment to home and community-based services and social supports. There is going to be money for housing in this. Now, what that's going to look like and the chunk of money that's going to be set aside, I'm not sure yet. But there's going to be money for housing with supports. So I think that's going to be an opportunity for people who have an interest in that. All right, how do we partner with managed long-term programs, managed long-term care programs? Well, let's start by thinking about who they are. And they're businesses whose need is to make sure at the December 31st that ledger is black. It's not red ink, it's black ink. Okay, so they're businesses, right? Got that? What their challenges are and the requirements. So what is it? What are their challenges and what are the requirements? That's the problem statement that you need to see as your opportunity. So what their challenges are, what their problems are, how can you be a solution to those? Because that's what they need. They need to find solutions to their challenges. So you need to be that solution. They are capitated, of course. They're incentivized to deliver care as inexpensively as possible. For God's sakes, if you haven't been delivering care for the least amount of money of anybody in the world, then I don't know who has. So who knows better than how to support frail persons at a very reasonable cost? Well, that's you. You've been doing it for 40 years, easily. So, for example, we know that, let me just use this as maybe not a very timely example right here in New York City, but you'll forgive me for that. There are ways to construct a care plan that meets the needs. Okay, so if you're in the old days, if you were a child, I ran a certified home health care program. You had the option of providing for somebody's nutrition. You could order 2 hours of home health aid to do the meal prep and all of that. But the Aging Network knows, well, that's a pretty expensive way to do it. How about if we just do home-delivered meals for this person and integrate that and pay for it? I'm not saying get it for free, but it's going to be a lot cheaper than a home health aide doing that. This is the stuff you've done to knit together service packages for frail people forever. And the barriers are huge, but the opportunities are also fabulous for you. And well, and that's the yes but slide, well, the barriers. Okay, all the challenges identified in that slide apply here, and who you are and just what it is that you do to help me is the central question that you need to answer. So when you're working to engage managed long-term care providers, that's what they need to know. And we talked about history. Contracting for services are probably not new to you. You've done this before. But I'll tell you that it is going to be different going forward. And if you're looking to provide services to business entities, such as managed long-term care plans, you'll have to have serious negotiation skills, and you're not negotiating for a grant, remember, with the government. The government's always here to help you, you know, and they want to do everything they can for you. But that's not what you're going to run into here, okay? These are hardcore business people. And that's not a pejorative term. That's just, let's understand what we're dealing with here. I'm not making any kind of judgment. You will need to know exactly how to price your services. You can't afford to lose any money because you're running on fumes as it is. I know that. So you can't afford to lose, but you can't use government money to subsidize. So if the meal costs $7.89, it costs $7.89. That's what it costs to deliver it. You can't charge $7 and use 89 cents from older American tax money. You got to charge them the $7.89. You got to know what your costs are. And this is actually new to us, really. I mean, it's, you know, there may be some of you that are skilled in this, but at a broad sweep in the network, this is not our customary behaviors. And you could well be competing with people here in this room as well, with each other. You need to know how to market your services publicly and to these programs, and that goes way beyond the outreach you're accustomed to. And you need to educate yourself. Learn about where there has been real successes. For example, the Veterans Administration has a program of home and community-based services for veterans with disabilities. It's been very successful, and where it's happened. And it uses community-based services like yours. That's the dominant. Because what do older people and disabled vets need most of? 90% of their needs are non-medical needs. Non-medical needs. So let's think, you know, the VA has actually thought that through, and where they've implemented this program, it's working very well. Well, and there are some peers organizations that are now contracting with managed long-term care programs. You need to transfer that knowledge that they have to your shop. There is a gradual improvement in the understanding of non-medical supports and the importance of those in long-term services and supports. So I think it's a better day to talk about that than it was 20 or 30 years ago. The most successful care, and this is a good piece for you to look at. The most successful models of care management, and I must say, back in the workshop that I attended this morning, there was no talk of multidisciplinary case management or assessment or anything. There was no talk of that. It was the nurse was going out from the managed long-term care. Well, that's not the most successful model in caring for frail people in their homes. The most successful model is integrating the disciplines of social work and nursing, healthcare. There's plenty of evidence on this, a lot of research on this. Now, the costs of doing that, the research is weak. So some research says, well, it's cost neutral. Some say it costs more. Some say it costs less. There's just no case to be made for that part yet. But the evidence on customer outcomes is very clear that the integration of health and social work in terms of the assessment and care management processes yields good consumer outcomes. So the opportunity and the challenge is to integrate the medical model with your social model. And that is an opportunity, but a very big challenge. But I urge you to pursue that. Pursue it, for even altruistic reasons. I mean, it's going to be best for the consumer, regardless of anything else. So, what's the strategy here? The strategy is that you're there to learn about you've got this meeting set up, you're there to learn about their problems in delivering community-based services to their clientele. That's your question. That's why you're there. You want to hear about that. And you want to engage in a discussion with them about that. And then you want to be able to detail your efficiency back to the cost and the outcomes that you can deliver for their problems. Imagine how you would do that. Propose, if they're not interested in a long-term contract, well, how about let's carve out a segment of your real challenging consumers. Maybe it's 10, maybe it's 20, and we'll work together. We'll bring in our case management with yours. We'll work together, and let's just see if we can't come up with a better outcome. I'll guarantee you will, but it's a risk you have to take. And the same notion is with the hospital transition. Working with the hospital, just say, okay, I understand you're medical, you have these concerns and the like. Let's carve out a group to work with, and let's see what we can do. Well, I know you can make sure Mary gets to the doctor. I know you can make sure that she gets her meds. I know you can make sure she's got food and can cook it, and if she can't, you can make sure she gets it. That's what they need, and that's what you do. And by the way, the notion of that with managed long-term care programs, they're not at risk right now for that hospital readmission. The hospital is, because the federal government will punish hospitals where they have high readmission rates. But if you remember my caveat about where we're going here, we are going to fully capitated managed long-term care programs, and they will be at risk for readmissions to hospitals. This is going to be a real opportunity. Challenge and opportunity, though. Okay, let's talk about informal caregivers. Informal caregivers are part of your everyday work. And you integrate them as you think about the older adult and you think about what kinds of services are going to be best to sustain that family unit or individual. There's really good evidence out there that by sustaining the caregiver, you can reduce expenditures or contain expenditures, care expenditures. We took a look. Excuse me. We took a look when I was with the state at those a like body of individuals. We'll say they're all 80-year-old women who had similar kinds of chronic conditions and disabilities. And so the control group this group was from the Aging Network. This group was from the Medicaid program. Same types of disabilities, living arrangements, and the like, with a lot of controls on this. And what did we find? We found that the Aging Services Network spent 1/5 the amount that the Medicaid spent for the like individuals. And what was the biggest factor was the caregiver, support of the caregiver, maintenance of the caregiver, keeping them active, supported, cared about, valued, all the things. So if you're a managed long-term care program, this is not going to be obvious to you. And this isn't what you do. This isn't obvious. Okay, that's part of our problem here. But it is obvious to me that if you engage you to support caregivers where they exist, that their bottom line is going to improve. It's going to improve. That ink will be black because they will spend less on formal services. This is a stretch. They don't know this. Not been part of their history or approach. This is another problem. You don't know about the customer mix, okay? So you need to know, I mean, you can't sell caregiver support to a population that doesn't have any caregivers left because they all burned out, okay? So you need to know their mix. So if they're not serving a population with active caregivers, well, then that doesn't solve anything for them. If they do, then you can really be helpful to them. As no surprise there, right? Many Medicaid consumers have exhausted their caregivers or didn't have them in the first place. Yeah, okay, we know that. So we need to know the customer base. We need to know, we need to imagine what services you would provide to support their consumers' informal supports. So you'd have to be able to describe that. You've got to be able to tell them how much that's going to cost, and how you improve their bottom line. That's what you tell them how you improve their bottom line. That's what they want to know. Consumer direction. Consumer direction in New York State has been sadly underdeveloped. I think it was just last year that we reached 10,000 individuals in the Consumer Direction Assistance Program. 10,000 out of 400,000. What's that? I mean, what's that? That tells me there's no commitment to consumer direction. Consumer direction, if you look at the national consumer-directed programs, the big programs like Cash and Counseling and others, where the consumer is empowered to determine how they spend their budget, and it's been remarkable in terms of how cost-effective that is. Consumers and their families, despite what we might think, actually know very well what they need and what they can use, as long as they have an understanding of what their choices are. That's the critical piece. They have to have an understanding of their choices. And when they understand their choices, they make very good decisions about how they use their money. So consumer direction needs to be lifted up, if you will. So managed long-term care, many of them do not, they have to offer consumer-directed personal assistance. They have to offer that. Now that, by the way, you know that's a very narrow slice of consumer direction. You know, hiring your personal care assistant is not controlling your budget. Okay? So if you have your budget of $2,000 a month, or whatever it is, you know, you may choose this month to go lighter on certain things and have that doorway widen so you can get your wheelchair into the dining room and be with the rest of your family. I mean, that's the kind of thing that people get to choose. And it's respectful. It honors their preferences and honors their decisions. I think there's an opportunity to educate managed long-term care programs on consumer direction because it's a good financial choice for them. And by the way, I just threw this up here because CMS, the feds, this is the direction they're going in. They're looking to have robust consumer direction in every state. And New York State is way behind. The leading states, about 25% of their Medicaid consumers of home and community-based services are in consumer-directed care. And that's where the feds want to go. And we in the Aging Network have implemented in some small parts, but still have consumer direction so we can learn from these things. And I'm repeating myself. Okay. We need to develop our consumer direction experience and how we can partner with managed long-term care programs around that. We need to tell them how to go beyond consumer directed personal care assistance and describe why. You know, those are the descriptions of why you'd do it if you were a managed long-term care plan. Okay, what are some other areas? Well, transportation. Transportation's costly, and they're going to contract for transportation, most of them. And if you provide transportation, there's an opportunity. But again, you got to understand your costs. Adult day services, again, maybe not the most politically correct choice today, but home delivered meals and nutrition, education and counseling, disease prevention, health promotions. And that's it. I'm done. So, I don't know. Do we have time for questions? How did I do? I didn't even time myself. What time do we need to break? A couple? Well, we've got one here.
Okay. I'll walk back. You must hold this right up to your face or it won't project.
Is there an organization or a website that is beginning to break down what the ACA is? I understand it's a huge document.
Yeah.
Is anyone starting to do what you were doing at the beginning of this?
Sure. I would urge you to look at Kaiser Health Foundation, KHF, for one. That's khf.org, I think it is. That's a very, very good site. The feds actually, I'm trying to remember the website, but the feds, you can Google ACA and federal sites, and there are you know, to varying degree, but Kaiser will be your best bet, and they really break it. They take it in chunks, and they have papers on the chunks, and you can get you know, a lot of resources there. Start there.
And another question.
Yeah.
You mentioned a couple of times opportunities and grants. On what level do the opportunities exist? Is it going from federal to state to municipality and then the CBO?
Well, for example, it's, you know, I'll just use BIP, which is by far and away the biggest. I mean, it's $2 billion a year. That's, even in New York State, that's better than pocket change anyway. So the design is that they're going to have this all then comes to the state, and the state will then has a set of priorities, and you can, by the way, look at that application on the Department of Health's website, and it's just type in BIP, because and within that, so for example, they're going to have money for housing with supports. Well, they're not going to build that housing, or they're going to contract with localities. I believe there's, I don't know. I shouldn't say that because I'm not sure. But the next thing they're going to do is there's going to be additional money for New York Connects, the ADRC, and that's going to go through the state office for the aging, but out to communities. So I'll make the plug. New York City doesn't have an ADRC, and I think that's a big mistake. But that's not my business. But you should look at what New York Connects can mean in New York City and what role you can play in that. I mean, I think, you know, that's going to be some real money. And there are other components, but basically the feds give the money to the states, and then to meet the goals, the state distributes, contracts with organizations. Yes.
Hi.
Hi.
Judy Zangwell, Sunnyside Community Services. I don't know if this is a question. It's really more an expression of concern.
Yeah.
But we're part of the Department for the Aging's Care Transitions
Yep.
piece.
Good.
But we're very concerned at the end of 30 days that our case management, overburdened, overtaxed case management program will be absorbing. And, this is a program with a proposed 30% cut. It has already been cut 15%. So you can imagine how we're operating. So do you have a solution?
Let's see. How much did I bring with me today? I actually don't have enough. Herein lies the rub. The easy answer that's almost impossible to achieve is that if you could be working with an entity, a managed long-term care, and there are fully capitated ones here in New York, who is at risk for these transitions, they ought to be paying you to do case management for those individuals. And that would be a great way to start and demonstrate to the other managed long-term care programs who will be, whether they know it or not, fully capitated within 5 years, I'm sure. So that's the best I can do.
I have a question.
Yeah.
What's your perspective on the difference between care coordinators and case managers?
Well, yeah.
And where the funding and type of deliverer of service will be?
Well, care coordination, case management, I gave up, I can't remember how many decades ago, trying to define case management, or I simply, whenever I talk about case management in detail, I list the functions, because then everybody can see, so that care coordination, case management, what you're talking about, there are these functions. Okay, so what was your other part of your question?
It's who is going to be tapped to provide that, because I know that traditionally within a lot of healthcare systems that has not been social work, that has not been community-based organizations.
Well, your fear is so well founded, and mine, I share that fear, because having done this work and actually implemented a ADRC type of thing, I learned early on that nurses are wonderful people, social workers are wonderful people, but they have a defined skill and perspective, which is even more important, philosophy of practice. One is protecting the individual, physician, medical model. The other is assisting the individual to be all that they can be, to live the kind of life they want to live. Those are two different perspectives, and it is critical to bring them together. Now, if I were king,
For a day or a year?
For whatever, I would, if you just look at that, this is my editorial comment. This is so wrong-headed. Building a care system on a medical model for people who 90% of the needs that they have are social in nature is the most expensive way you could possibly do it, and not very good outcomes. Why would you do this? I don't know. Somebody said to me over lunch, if you talk about government, you have to leave the word logic out of it, because it just doesn't fit anywhere. So that's my only explanation. But we had an opportunity here to really redesign. We just shifted to a different medical model, and basically the only goal was to control costs. So
The almighty dollar.
yeah.
Other questions? We actually have a little bit of time. I was off on my schedule, so anybody have questions, comments?
Good. Good. That means I get on the train a little earlier.
There's a lot to absorb in what it is that you've shared. And
So you asked, I can give you my slide deck, and you can put it up on the website, too.
yes, and I think that that will be helpful because it's
Yeah.
many layered.
Yeah, oh yeah,
So-
it is. And but you know, the basic message here is, for God's sakes, the world is changing now. Seismic shifts, sea change. You really have to figure out this sea change and where you're going to go with it, because it's going to happen. I mean, it's the law of the land, and that's that.
Yes. Well, that's for that bodes for lots of hard work in the future, which we know that we have anyway.
That's right.
And all as many, many more people age.
Right, exactly.
So it's a interesting juxtaposition. Oh, yes, we have a question or comment.
You got to watch him, though.
I'm not clear on how relevant this may or may not be, but what is your take on oversight on all of this stuff?
Oh, well, that's a very big question. You know, the health department basically is kind of running the show there, and the oversight. Well, you know, there's two things. I mean, I have a lot of friends in the health department, so this isn't intended to be all that bad. But you know, they're an enormous bureaucracy. I mean, they're enormous, and to get regulations, to get, you know, this letter signed from over here to here, to even do the smallest thing, it takes them forever, and so that's a problem in oversight. And the other is you know, do they have adequate personnel to oversee this? Well, I think that's, you know, I think that's a question that remains to be seen. I'm concerned about the rollout and a lot of the stuff that is going on that is very disturbing when you think about who it impacts. We're talking about very at-risk, frail, older adults. I mean, this is serious business. This is life and death for these people, or damn close to it. And I mean, it was so disturbing to hear that, well, if you didn't get in the queue, Medicaid approved and all that by the 19th, then you can't get it. You can't get service until the following month. I mean, really? I mean, really? If they need service, you know, if they're frail and need service, that makes no sense to me. So I think that's an oversight problem. I mean, you know, they're treating managed long-term care plans like insurers. That's fine, but that's not fine when you're talking about serving frail, at-risk populations. You know, it's not about waiting, you know, having these waiting periods and so forth. It's about intervening as quickly as you possibly can. That's what's going to give you the best outcome. So I think there's a lot of issues around oversight. And I'll go back to this notion about, you know, and this is the ACA, I understand that, but there are these regional advisory boards under the ACA, and you know, I mean, get a voice at the table if you ask, you know, that's part of it.
Since you have a role with AARP at a New York State level,
Yeah.
and I know that we have our New York State person in the room, where is AARP in trying to advocate for some of the
Good question.
efforts to ensure that this actually is implemented from the perspective of meeting the needs of the older adults, not meeting the needs of the insurance system?
Sure. Well, AARP is very, very active in Albany, and will be increasingly so this coming year, especially around the delivery of long-term services and supports. That's a major focus for AARP New York, and that includes, you know, all of these issues, delays, all of that. I mean, none of that is going to escape us, and we're going to ask our decision makers to be accountable for those kinds of things, and we will do so relatively aggressively. I can assure you.
So I'm going to do a plug for the fact that when they rushed to put MMLTC in place, they left out hospice,
Really? I mean,
that you couldn't actually
Yeah.
be in and get both. So I just plug it as a point that if it's not on your radar screen,
It should
please
be.
put it on the radar screen.
Okay.
Because there are people for whom they need services, and they really need hospice services, but you can't, what do they call it, double dipping in some weird, bizarre way. They changed it
see?
for the affirmative?
All right.
Really? Like it's actually working? Okay, thank you.
Look at that. ARP changed that without even doing anything.
The credit goes where credit's due. Who knows? Anyone else? Questions, comments? But that's great news to know, actually.
Yeah, it is. That is good.
We'll just have to convince the providers that it's actually shifted.
Okay.
Sorry, that's my
Okay.
bias. That was me, Margaret Rife, speaking, not Executive Director of Jarvie Commonwealth Service. It just came out of my mouth. But thank you so much, Neil, for
you.
coming and presenting to us.
My pleasure.
You all have a few extra moments to make your way, not very many, to your afternoon workshops. Again, evaluations, even if you're leaving early, we're happy to get them. So drop them off at our registration tables and have a good rest of the afternoon.